Hello everyone. We will talk about implant prosthetic steps in an easy and enjoyable way and solve side effects in this prosthodontics on Friday. I am Jo In-ho, the MC of the program. Today, in this session, we are going to talk about the second topic of the top 5 hot issues in a series. The speaker is Professor No Kwante, Prosthodontic Department, Kyunghee University. Hello. This is the second session of the implant hot issue in terms of the prosthesis. Would you briefly introduce what you are going to say? There is no correct answer to implant prosthetics. Based on my experience, the approaches and ideas regarding that has changed. So I'll introduce my cases and I'm going to talk about the selection criteria for abutments. I look forward to your presentation. If you're watching this broadcast on the dental site, on the right-hand side, you will find the chatting window to communicate in real time. Please leave questions there, which will be addressed during the Q&A session. I ask for your active participation in the discussion. Let's get started with the second topic of the hot issue with Professor No. Hello everyone. I am No Kwante. I'm with Kyunghee University. Thank you very much for inviting me to this wonderful program. Today I'm going to talk about how to select abutments and prosthesis in restoring multiple implant cases. I will talk about the selection criteria that I have used, and I'll also talk about the abutments that I have used. In the past, for implant prosthesis, I used to use cement type without giving it a lot of thought. And I don't use very strong cement, like a temporary cement. If problem occurs, it is removed to maintain. Going through it, I experienced some problems in removing it, and the crown fell off, so I changed my approach. Recently, I use a cement type just a little bit, but as you know, I use the combination type, ER-type prosthesis. The combination type has the advantage of this cement type, which is the connection between the abutment and the implant is very accurate. An error can occur between the abutment and the implant. The conical sealing is properly achieved. It can be set like a general crown prosthesis. If we want, the implant prosthesis can be removed using the screw hole to repair. For posterior implant, this approach is used for single or multiple implants. This is the approach I used to use quite a lot. Using the approach, one day I realized implant crown is delivered without adjustments. Implant level screw type can be used clinically. That's what I thought. So when we even make a profile, we don't use the custom abutment. After the cementation, screw type is used, then custom abutment is not necessary. So that's my recent approach that I employ. That decreases the setting time considerably. There's no time needed for the crown cementation. accurate impression taking and without error or with reduced error, the delivery can be done within 5 minutes. If the path of the implant is not appropriate, if there is a contact problem, we cannot apply this approach. If the implant path is proper, I use this approach quite a lot these days. In using this, we need to select the abutment there, stock abutments, or sometimes titanium link is used. When we use a stock abutment, we choose them based on the cervical diameter. 6 to 7 millimeter diameter abutments are used for the molar, and 4 to 5 for premolars according to some criteria. If the implant depth is appropriate, the initial profile should not be as thick as this. Therefore, the selected stock abutment is 4.5 millimeters in diameter even for posterior region. 5.0 is sometimes used. For the gingiva height, it should be at least 2 millimeters. If you look at this slide, the gingiva height, it is called a gingiva color. If it is higher, the profile would be slimmer with the same diameter. The bigger the gingiva height, the profile will be slimmer. If an implant is placed at the proper depth, 4.0 diameter and 3.0 can be used, and 2.0 can be used, but we need to avoid 1.0 as much as possible. If the distance between the cement gap and the implant connection is very short, that is not very good, and the profile would be thick. So 1.0 millimeter diameter abutment will have very fat emergence of the profile. The same is true for choosing titanium link. In most cases, I use 4.5 diameter abutment even in the posterior region. To place an implant appropriately in terms of the depth, biologically, platform switching implant, the TS type implant, if it is placed on the bone level, when the gingiva is thin, bone resorption can occur. Therefore, it should be placed below bone so that bone is not resorbed due to biologic width. That is recommended. This is the two-dimensional section. We need to consider gingiva recession when gingiva profile is created. The depth to the implant connection from the crest of bone should be deeper. If you place 3 millimeters from the alveolar crest around the implant profile, gingiva will have a recession. 3 millimeters from the implant connection to the prosthesis margin is not sufficient. Considering 2 or 3 millimeters from the crown margin to implant, it should be placed at least 4 millimeters from the alveolar crest for proper fabrication of implant prosthesis. In this case, implant profile will emerge thin and the profile will start 1 or 2 millimeters subgingiva. The profile will be made with the crown. So number 1 and 3 are using 4.5 millimeter diameter, and the middle one 5.0 millimeter diameter. There's no problem aesthetically. When the abutment is thin at the starting point, it has less interference with the bone. The soft tissue will become thick surrounding that area. So big diameter abutment is not necessary, especially in the premolar area. 4.5 millimeter when the gingiva height is 2 millimeters. Clinically, in most cases, there's no problem. If we use a thinner abutment, it would be better. If you look at this X-ray, here the smallest diameter, 2 millimeter gingiva height is used. If the emerging area needs to be more concave, custom abutment or trimming the stock abutment can be done. Implant the crown to be aesthetic, and if the implant is placed in the appropriate depth, the beginning profile doesn't need to be very thick. And profile can be made with a crown. Screw type, when it is used in the posterior region, I was worried that screw type internal connection, if implant sinks down under occlusion, may occur. So I carefully checked the occlusion using the silicone. The thickness has been measured for a long time, and I observed the shim stock whether it comes out easily or not. Single crown case in the posterior region with the screw type, no such problem occurred. If you look at the papers, the sinking occurs in a narrow range from 2 to 11 micron. Clinically, it doesn't sink up to creating under occlusion, but sometimes we observe the sinking. If the custom abutment is bigger than the healing abutment, at the beginning it sits not fully, and over time it goes down. It may look like sinking. So I did an experiment using an artificial gingiva. The thickness of the healing abutment is 4 millimeters in diameter and gingiva height is 3 millimeters. This can be different from actual mouth. The abutments are custom made from 5 to 10 millimeters wide. They're connected with a 10 versus 30 Newton centimeter force with a 30 centimeter connection. The graph at the bottom, depending on the diameters, they are not fully connected. This is different from actual oral situation. When we deliver crown, not fully tightening the connection, as it gets seated more and more over time, in the gingiva, it may cause under occlusion later. We need to pay attention to this. When we deliver the crown, we need to take time for retightening, not to create the clinical problem. For a single case, I use the approach previously mentioned, implant level, screw type. Aesthetically, we can change the profile with the prosthesis. In a multiple teeth missing case in the posterior region, I use a different approach. Implant sinking problem and the TMJ can be displaced when teeth are missing. When prosthesis delivered, the occlusion can be changed. So, if possible, natural tooth-like provisional is provided so that chewing is continued to stabilize TMJ before prosthesis is delivered. When multiple teeth are missing in the posterior region, supragingiva, like a 0.5 millimeter supragingiva margin is given after provisional is delivered and occlusion is stabilized. A final prosthesis is delivered from time to time. May I ask a question at this point? Sure. When multiple teeth are missing in the posterior region, do you always use the provisional before going to the definitive prosthesis? My ideal cannot be exercised all the time. Sometimes I have to do insurance implant and a patient asks for very quick treatment. I cannot use the ideal approach all the time, but still I use a standard approach, and I find that some patients who need to use a temporary. This is the criteria that I use. Even for general crown bridge, due to lack of anterior guidance, the patient may have an open bite, then they're very sensitive to occlusion. Class 2 and open bite patients with unstable occlusion, when we guide the CR, if it is very different from the current situation, we need to evaluate them under this. In general, when molars are missing and only some premolars exist, the vertical loss can occur and the fremitus in the anterior region can occur. And I want to provide support for the occlusion to avoid the fremitus. And I need to evaluate the patient with a higher vertical dimension than the current one. If a patient has fremitus or general mobility in the teeth, I try to explain to the patient that a temporary would be helpful. Do you use a temporary for a patient with a heavy occlusal force? Yes. Thank you very much for the good answer. You can proceed with your lecture. When a patient has a fremitus, in this case, let me go back. This region, the abutment level impression is taken. This area will be restored. The anterior teeth have labial version as it touches the premolar while chewing. If you restore at that height, fremitus, the TFO would not disappear in the anterior region. If it is not due to the perio problem, but simply because of the stretched PDL, if the support for the occlusion is provided, the mobility would disappear in many cases. In this case, the fremitus is avoided and temporary is provided. Adjustment to it is observed before final prosthesis. After a year, anterior region is stabilized and it is very well used. In the posterior region, depending on how much defect is there, in general, if number 7 is single, it's no problem. If number 6 and 7 are missing, if the anterior region is stabilized, no temporary is necessary. When 5, 6, and 7 are missing, the occlusal support would be unstable. In that case, a temporary would be provided after explaining it to the patient. Next, custom abutment can be used like this. If it is a mixed dentition with natural teeth and implants, a temporary is made like natural teeth. An impression is taken for all of them together without coping like abutments. And for the final prosthesis, custom abutments can be used like this. In a multiple implant prosthesis similar to the one before, temporary is made easily and impression is taken and transfer is made easy. Custom abutments can be used like that. Next, in this kind of a patient, the oral environment is not very good in many cases. These days, my former classmate, Dr. Lee, does a lot of this kind of reconstruction surgery, or when multiple implants are placed where the alveolar bone was severely resorbed. Cement type or combination type prosthesis is split together. When implant paths are not very good, it is difficult to remove all of them together. In order to facilitate the maintenance, I do the multi-unit abutments. 4 can be splinted. Even though the implant paths are correct, If it is the combination type, it is difficult to remove. Using the multi-unit abutments, it is easy to remove, and impression errors are made less because of the stop. Because of such advantages, multi-unit is used in this kind of cases a lot. Multi-unit abutments. There are straight type on the left, and it has different gingival colors, and the angled abutment with 17 degrees inclination and 30 degrees inclination. The angled multi-unit abutments on the right. The screw and abutment are separate, so two-piece abutments. On the left-hand side, those are the one-piece abutments. When I choose an abutment, as I said before, I don't like the one with the short distance between the abutment connection to the margin of the prosthesis. So when I choose multi-abutments, I try to choose at least it should be 3 millimeters. Implant position should be 3 millimeters from the gingiva, so that I can choose this type of abutments. Whatever abutment we may choose, we need to consider that factor. The angled multi-unit abutments in the mandible, we can avoid the metaforamen, and implants can be placed a little bit distally to use the screw-type prosthesis, and the direction can be changed using this. Or in the maxilla, implants in the anterior and those in the posterior have different paths. Angled multi-unit abutments. The angled portion, the color is long, therefore that should be considered when placing implants. This is a different implant. 3434 implants are planned to be the screw type, and multi-unit abutments are connected. In the posterior region, tissue-level implants are placed. Cement type is used. For the anterior implants, the height is high. 4 are splinted in the combination, and if directions are different, it is difficult to remove them. So multi-unit abutments are used in this case. Next patient. If you look at the intraoral pictures, the patient is in her early 30s. If you look at the pictures, the implants were placed in another clinic. The condition is not very good. Aesthetically, vertical dimension is low. The implants have a crystal bone loss, and all the implants are not usable. It is very difficult to do the surgery again. Quadrant 1 and quadrant 2, the direction is quite diverged. For prosthesis, multi-unit abutments can be used for 30 degrees inclination, and only usable implants are selected, and screw-type prosthesis can be used for ease of maintenance. So I use the multi-unit abutments in this type of cases. A similar case, let me move fast. Implants and the teeth positions are not very good. We cannot use the cement type. The implant positions are not matching the teeth. Cement type prostheses are not available for this case. I milled the cobalt chrome and I built up on top of it to make one-piece abutment. The vertical space is short and not many available options are there. So in this case, multi-unit abutments are used for the prosthetics. About 10 years ago, I did this case. In the past, we used double scan and full zirconia milling, but recently we hardly do that. Try-in is printed out In the past, the crowns were long, so I didn't do the sectioning, and I used the cement type one-piece prosthesis. This type of prosthesis has some problems in later maintenance, so multi-unit abutments are used these days for the prosthesis today. Professor No, may I ask another question? Sure. In the full mouth, if we do the immediate loading, what type of abutments do you use? For the full mouth, in the past, I used the guided surgery. Implant positions are determined, and abutments and crowns can be fabricated together, but this is sectioned and it is splinted later. This is a comfortable procedure, but sometimes I'm concerned the cementation can occur and prosthesis can fall off. If it is loaded without cement, it would be better. So recently, for immediate loading, I don't fabricate the prosthesis at the same time. Multi-unit abutments are used, and without a model, digitally it is loaded. This is a case. This patient came to me. For a full mouth, what is important is the denture. They are extracted, and the appropriate denture should be used for appropriate positioning of implants. So CT is taken for appropriate implant positioning. Did you do the guided surgery? Yes, I didn't do the surgery, but we used the guided surgery. Multi-unit abutments with a 3 or 4 millimeter collar. Scan body appropriate for that existed. I didn't do the scanning. There's an existing denture and impression is taken with a denture. So cementless approach is better for ease of removal later. So this is the prepared contents. I hope my lecture is helpful to many of you. Thank you for your listening. Thank you very much for the wonderful lecture. Let's get started with Q&A session. Audience sent us questions in real time. Unlike Friday, fighting to Professor No. Very good lecture. Thank you very much, Professor Nogwante. And there's some comment about me. Very good bow tie. Let's look at the questions. Someone called Young gave us a question. What is the most important thing in selecting abutments? Would you summarize what you said? Sorry about not including the summary in my presentation. There are many ways to it. For a single case, cement type or combination type were used. As I said before, these days, implant level screw type is used. The prosthesis can be made with the correct impression taking. But when you select an abutment, you need to be careful not to select the one with too much contour. If you place an implant to a proper depth, 4.5 millimeter diameter can be used even in posterior region, and the shape of the prosthesis would be good. We talk about the emergence profile, the divergence. Is there any criteria for the inclination or angulation of the emergence profile? I hear people are talking about the criteria of 30 degrees or 40 degrees. but the starting part can be slimmer, and it can get bigger subgingivally. Sorry for the interruption. You can continue. For multiple implants regarding the occlusion, custom abutments are used, as I explained before. For multiple implants, if the case has a severe gingival recession and implants are placed with some distance apart and one-piece prosthesis is designed, depending on the implant path, combination prosthesis would be difficult to remove them, so multi-unit abutments are used. So for ease of maintenance, that is used, and recently for immediate loading, that is used too. Thank you for the good answer. Let's have a look at another question. This is from someone called 보철속속. Very good name. What prosthetic method do you prefer when the distance to the opposing tooth is short in the posterior region? This is a difficult situation. I have some slides for it, so let me explain with the slides. If you look at it here, actually this is not my case, and I ask for your understanding for using someone else's case here. In this case, number 7, the opposing tooth is coming down and the space is short, and the stock abutment would not be appropriate. Sandblasting is done on the custom abutment with gold crown and metal crown. Actually, gold crown is not easy to do these days, and metal crown has some challenging aspects. I used to use this approach, which is no longer used today. Another approach is gold UCLA abutment is used. From the abutment to screw, the distance can be short for this type of prosthesis, but gold is expensive. Cobalt chrome or molybdenum type of metals can be used, and that is called MP cast. Such metal can be cast. However, the material of abutment connection and implant material are different. Therefore, oxide film is a concern. Implant level screw type, this approach is not used by me. My approach is, for example, in this case, the space is not too short, but in a case where the space is short, and it is also dependent on the depth of the implant placement. When implant is placed in sufficient depth, titanium link or stock abutment can be cemented for this type of prosthesis. If implant is placed too shallow and the space to the opposing tooth is just 4 millimeters, when I mill the custom abutment, the tooth shape can also be milled. Connection part material would be the same. So this type of prosthesis is what I use these days. That is called the monolithic titanium crown. What is the material? Is that titanium alloy. So the corrosion between the heterogeneous materials would not be a concern. That is right. Thank you very much for the good presentation. Lastly, would you give some words of encouragement to the junior dentists who are studying and working hard for implantology? There is no correct answer to implant prosthesis. Various approaches can be used. I observe other people's technique and deliberate on them and utilize them in my clinic. There are many good, excellent lectures in dental site. When you're a beginner, you can get a lot of help from watching the lectures. That would be a good way to start. Thank you very much for mentioning dental. Today, you talked about the multiple implant restoration considerations for selecting abutments and prosthesis. You have given us very good tips. Thank you very much. Prosthetics on Friday. This program needs to be closed. If the answers are not given to your questions, the answers will be provided online. In the next hot issue lecture, narrow implant, prosthodontic consideration and longevity will be delivered by Professor Pearan, Kyunghee University. Thank you very much for your watching. Thank you very much.
수고하셨습니다. 감사합니다.